morning everyone. Thank you Aditi. Thank you respected chairpersons. Pregnancy loss is physically and emotionally taxing for the couples, especially when faced with repeated losses. No doubt, it is equally frustrating for the treating obstetrician whenever we are unable to figure out why this is happening. Bad obstetric history implies previous unfavorable fetal outcomes in terms of 2 or more consecutive spontaneous abortions, early neonatal deaths, stillbirths, intrauterine deaths, growth restrictions, and congenital anomalies. There is another terminology, recurrent pregnancy loss, RPL, which is 3 or more consecutive pregnancy losses before the age of viability is achieved. That is 24 weeks according to most of the countries. Most. So now WHO tells us to use the criteria of 500 grams instead of the weeks of gestation. It can be primary RPL when there is no successful pregnancy outcome ever. And secondary when there is at least one prior live birth. These are the references which helped me to make this presentation precise. And yes, Aditya, I will only be talking about the workup. So I will tell you the guidelines and recommendations which are in place as standard guidelines. Irrespective of the incidence of recurrent pregnancy loss, there are many more pregnancies which fail even before being clinically recognized. So only 30% of the conceptions result in live birth. So the main question is, when should we start evaluating such couples? Well, there is no specific answer, but most of the authorities agree that we should start evaluating after the 3rd consecutive loss. Earlier evaluation after 2 losses is warranted in case the cardiac activity was identified before the pregnancy loss, if the woman is more than 35 years of age, if the couple has had difficulty in conceiving, the conceptions were after infertility treatment, and if the previous conceptus was subjected to karyotyping and that was found to be normal. In such cases, you must evaluate them a little early. These are the proposed etiologies. We all know this is theoretical, but as you can see in almost 50% of the cases, the cause remains unexplained. So unfortunate. So the high baseline rate of spontaneous and recurrent losses, lack of consistent definition of RPL, limited access to the pregnant tissues for studying the disorder, and finally, and surprisingly, remarkably good prognosis for live birth after recurrent losses. All these combine to frustrate the aims of making diagnostic and therapeutic recommendations. So, how to go about it? How to do the workup? The workup includes finding out the risk factors: advanced maternal age, stress, occupational or environmental exposure to certain substances, excessive consumption of alcohol, smoking, and obesity or significantly underweight couples. Yes, couples. Then taking out extensive medical and family history with special emphasis on diabetes, thrombophilia, and PCOS. Then comes the screening for genetic factors. The key question is, what is the value of these genetic tests? We are very enthusiastically ordering the list of genetic tests, but then we don't know what to do about it. So always, the counseling is very important. It is crucial to explain to the couple before testing that investigations may not identify a likely cause for the previous losses and what this means for the future. It is equally important to explain that there are some causes for which there is no known treatment available, because most of the couples obviously would want to know the exact cause for their loss and what is the recognized treatment available. And if you are not giving them that, then they will be distressed, obviously. The genetic etiologies, 2 to 4% of them are associated with parental translocations, that is structural rearrangement on chromosomes. So we need to do the parental karyotype. Most early pregnancy losses are morphologically abnormal. So karyotype of the VOCs, the products of conception. It tells us whether it is due to morphologically abnormal embryo or fetal aneuploidy. Then culture of meiosis. Culture of meiosis does not distinguish between maternal contamination or a normal or euploid fetus. So there is no recommendation, no routine recommendation to do the culture of meiosis. So the genetic techniques, as we have told, the parental karyotyping, conventional karyotyping, fish. The problem of fish is it uses only the probes for certain chromosomes. So does not necessarily identify other chromosomal abnormalities. In that case, array-based comparative genomic hybridization (CGH) is better because it is looking at all the chromosomes. So the limitations of conventional karyotyping and fish are avoided with array CGH. Next generation sequencing, it is promising, I can say, in near future, not right now, but yes, it has advantages. So these genetic tests of the pregnant tissue, they are not routinely recommended. Only conditional recommendations are formulated. Then thrombophilia. For hereditary thrombophilia, there is no recommendation to test for that. For acquired thrombophilia, yes, we have to go ahead with the testing. It refers to antiphospholipid antibody syndrome, the acquired thrombophilia. It is diagnosed in presence of persistent antiphospholipid antibodies, vascular thrombosis, and/or pregnancy complications. The three antibodies we very well know: lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. Out of these, we need to test the first two, LA and ACL, after 6 weeks of abortion, not immediately. That is a very important point. Immunological screening, yes, immunological causes are there, but the screening for HLA typing, the anti-HY antibodies, cytokines, natural killer cells, not routinely recommended. Only test that we need to do is ANA, anti-nuclear antibodies, because they are detected in many cases of immunological cause for loss. And of course, that antiphospholipid antibody needs attention. Metabolic and endocrine factors, 17 to 20% of these they attribute to recurrent pregnancy loss. So we need to screen for thyroid dysfunction, TSH and TPO, thyroid peroxidase antibodies. If these are positive, then go for T4. Gestational diabetes, yes, it is a cause of bad obstetric history, and we need to do the oral glucose tolerance test and glycoside hemoglobin. For tests for PCOS and disturbances of insulin metabolism, there is no recommendation to do fasting serum insulin in all patients. Prolactin we should test only if there are clinical signs of hyperprolactinemia. Ovarian reserve testing can be tested with the help of AMH, we all know the antral follicular count, inhibin, FSH, the estradiol, but they are also not routinely recommended. Lutein-based insufficiency can be tested with androgens, LH and hyperhomocystinemia, but there is no recommendation to do that also. Yes, this is important. Anatomical malformations of the uterus, they need to be done in all patients. For congenital uterine malformations, the hysterolaparoscopy is the gold standard. We can also do HSTs and USDs. For acquired uterine malformations like submucous myomas, endometrial polyps, uterine adhesions, the preferred investigation is 3-dimensional transvaginal sonography. Only in case this is not available, then only go for MRI. So remember, MRI is not the first line investigations in finding out the malformations. But if the malformations are found, then the entire urinary tract needs to be assessed. Infectious etiologies are suspected to play a role, but the routine infectious screening is neither appropriate nor productive. TORCH, I want to make a point here, they do not cause recurrent losses. So, their serological investigations are not routinely recommended. There are certain environmental factors like exposure to organic solvents, medications, ionizing radiations and toxins, but I think history taking is more important in these cases. There are causes like preeclampsia, preterm birth, PROM, malpresentations leading to cord prolapse. they are not recurring. Although they are not recurring, they are a part of bad obstetric history, and individualized approach here is more important in the ongoing pregnancy. Similarly, cervical insufficiency. We get to know about it from proper history taking and ultrasound in the ongoing pregnancy. Assessing the male factors about lifestyle factors like alcohol, smoking, exercise pattern, extremes of body weight. Assessing the sperm DNA fragmentation in couples facing with RPL can be considered as for explanatory purposes only based on indirect evidence. PGTA, this is a very helpful test, but only for couples undergoing IVF. So before the embryo is implanted, we have to check for peri-implantation genetic testing for aneuploidy, but only in case the couple is going for IVF. So all said and done, with due respect to the guidelines and recommendations in place, I found this table by Dr. Vivek Krishnan in his book, and it really sums up the whole workup, which tests need to be done in all patients and what are the tests that need to be done in selected patients. So these are all the tests available. We need to be very particular in advising tests to the couples. So although not an intervention as such, but informing couples confronted with RPL about their prognosis in the next pregnancy is an essential part of the management, and it allows the couples to plan for or against their further pregnancy attempts. And I think at least this much we should be able to provide to the patient. So I think that is all from my side. Thank you very much.